So you probably noticed as we go through these lectures that they're not all tied to certain organ systems or things, and that's because they never show up that way in the emergency room. And so there's sort of a hodgepodge of things that occur. In the short time that we have together today, we're going to talk about soft tissue injuries, really the bread and butter of the kind of things that we see in the ER. And much of the things that I'm going to talk about are really common things. Many of these things are just going to be reminders. I don't think I'm going to tell you anything that you don't already know. But probably the first most important thing is understanding the terminology. And I don't mean about you understanding the terminology because I already know you know that, but an opportunity to share terminology with patients. And as we talk about sprains and strains, it's important, that the patient understands that sprains, are injuries to ligaments, those that connect bone to bone. And that strains are injuries to muscles or tendons that connect bone to muscle. And both of these involve some sort of a stretching or tearing of tissue. And so it's important to have patients understand the terminology. I always like it when I've seen a patient and I've told them that they had a fracture, and they say, "Oh, good, because I thought it was broken," and it's go, "What?" So it's important to know that. So here's the West Point sprain grading system. There are a whole bunch of systems out there. For some reason, we always like to develop a new system. But it's pretty common to really look at sprains and strains sort of in 3 grades, as it shows here, with grade 1 being the very minor one, and with some microscopic tearing and minimal swelling, and really no instability, of the joint involved. And usually a person has full weight bearing, maybe a little bit of weight bearing, maybe a little bit of a limp, or if it's in the lower extremities. And rarely, and actually I've never seen a grade 1 that had any kind of ecchymosis. Whereas in grade 2, there's a partial tearing and moderately severe swelling, some mild or moderate instability of the joint, and usually unable to have any kind of weight bearing. These are the most common kinds of things that we see. And then with grade 3 being a complete rupture with severe swelling and joint instability and absolutely unable to ambulate at all. And these are the folks that end up being referred, to the orthopod. So as we take care of these soft tissue injuries, it's important to remember the various things that we do to take care of them. And we're using the word pricer, and go through that just a little bit. Very common knowledge things, with P being protect the injury wherever it is. This might involve using crutches or some sort of an immobilization device. But again, usually protecting that injury is something that we protect for a very short period of time because we want to get them ambulated. R is for resting the involved area, again for a very short period of time. For those of you who've been around for a lot of years, remember when injuries like this, we would elevate them and we would ice them and we'd do everything for a long period of time when we found out, that was not good for that injury and in fact did not assist in rehabilitation. So excessive immobilization, certainly among the elderly, can result in some pretty bad stiffness of the joint and really, will not enhance their rehabilitation. So getting folks mobilized, particularly in the pain-free range, is highly encouraged. The I for ice, ice is our friend. It's not directly on the skin, however, because then we forget what we just talked about in terms of protection. We want to protect that skin, so we want to use ice. We want to make sure that it's done appropriately. We always tell folks at home, to put the frozen peas pull out of the fridge and use it on top of the area. I don't like frozen peas, so I always say frozen corn. So thanks for laughing for that. Okay. Shouldn't apply ice for more than 30 minutes at a time. After that, it really doesn't do much good. And, there's not a lot of data out there about the value of ice, but we know that it works. We know that it decreases pain, that it decreases swelling, and things like that. So it is a good thing. Compression. There's always some discussion about whether you ought to compress the injury or not. We know it does reduce edema, it disperses excess tissue fluid, and it aids in venous return. And the only important thing about compression is to make sure that when we do a compression, that we make sure that the pressure is more distally than further up. Otherwise, we end up putting sort of a semi-tourniquet on the area, which we don't want to do. And E for elevation, again, reduces edema. Try to elevate the part that's injured sort of above the level of the heart. So there's some people that say, well, we ought to use compression and elevation at the same time. Some say you shouldn't. Whatever seems to work, I think they both work. The maximum benefit for any kind of elevation is in the very first 72 hours. If we're not getting good, healing by that period of time, there's something else going on. And R for rehab, certainly physical therapy or being sent to a physical therapist is very important. Particularly when the injury is around joints, we want to get the folks back ambulating quickly, particularly in the issue of shoulders. Getting the shoulder working quickly is going to help in the long run. So that's important things to remember about soft tissue injuries. We'll talk a little bit now about laceration management. And if you're like me, if you work in the ER, there's always somebody there that that likes to sew up lacerations. And in fact, sewing up a laceration is not only a science, it's an art. It becomes an art form in terms of learning how to do it and being very proficient in it. So, and we're going to talk for a few minutes about some of the tricks of the trade from lacerations. So first one is cleaning. Now, we do know that lacerations, particularly dirty lacerations, really can't be adequately cleaned unless we anesthetize it. So getting the anesthetization in there early, right as soon as the person gets into the examining room, is extremely valuable. And so there ought to be some high priority in doing that. It helps to relieve the pain. It helps stop bleeding. Now here's the real great question: is we used to somebody come in with a bad laceration and you'd plunk their arm into a big bowl of betadine. And why did we do that? Well, two things. One is then we were doing something for the patient and they thought we were doing something. But more importantly, it gave us time. So we go see another patient while the arm's being soaked. We find out now that soaking it is not very valuable. It doesn't do much to clean a wound. And in terms of betadine, betadine is okay, shouldn't be put directly into the wound because there is some tissue toxicity that goes on. And we ought to dilute the betadine to about 1%, and this works very well. Cleaning wounds, particularly dirty wounds, sometimes just after you anesthetize it, get them over to the sink, good old soap and water, to clean that area is very, very valuable. Again, after the local anesthesia. I actually like pulsatile jet irrigation. I think it works really well and helps really get out a lot of particulate matter in the area, and I think we should be doing that routinely. Wound care chatter. So if you remember anything that I've talked about today, this is the slide to remember. It's how we talk to the patient while we're taking care of their wound. And I'll tell you a story about one in just a minute. But I really like this. I'm going to do my best to make sure that you have as little discomfort as possible. Let the patient know, that we're interested in their pain threshold. I'm cleaning the wound very thoroughly so that they know that, you're there purposefully. You're going to take care of that wound. You're going to take as much time as you need to clean the wound, and the patient needs to know that. My favorite. I've tried very hard to remove all the foreign material I can find, but there's always a chance that some still could be hiding in there. Very important. Now, about a year and a half ago, I had the opportunity of reviewing a malpractice case where a guy, about 55-year-old guy, was up on the roof and getting some leaves off his roof and slipped and fell down the ladder, and his foot caught on one of the rungs of the ladder and just lacerated the dorsum of the foot, left it wide open, and he fell down on the ground, got debris and dirt and leaves and all kinds of stuff in that wound. Ambulance comes, takes him to the hospital, bring him in there, and get him right into the room, and the PA sees the patient, and at the same time, the doc comes in, looks at it, and says, well, okay, let's get this cleaned up, let's get an x-ray, and so the PA cleaned it up really well, got an X-ray, brought it back, cleaned it some more, irrigated out with some pressurized irrigation. Looked at both the doc and the PA looked at the X-ray, didn't see any foreign body in there. Went back, and the doc comes in, looks at the laceration before it's sewn up. Then the PA takes the right amount of time to explore the area, make sure that she didn't see anything in there, sewed it up, and then the doc saw the patient again. So during this period of time, both the PA and the doc saw the patient. Everything, in my mind, they did very appropriately. Gave them aftercare instructions. 24 hours later, the patient is seen by a podiatrist because they're complaining of some redness around the area. A podiatrist said, looks fine to me. Another 24 hours later, they end up going to a foot doc, a orthopod, who had not been referred to, and now the area is really red and puffy, and so the physician opens up the wound and says that he finds a bunch of black particulate matter in there, and irrigates that out and cultures it, and the culture turns out to be some weird fungus. I think it was aspergillus or something like that. And of course, the reason I'm telling you this story is it ends up in a lawsuit. It goes all the way through depositions, all the way actually goes to trial before the jury finds in favor, of the defendant because they did everything right. Now there were a few things. The radiologist, after the fact, the radiologist report said that there may have been, some opaque material in the X-ray. Now, you don't know if that occurred. That X-ray was taken before the irrigation and removal of the particulate matter. Now, the reason I'm telling you that story, is you can do everything right, and you're still going to end up in court. But I think it's very important when you talk to the patient, especially during minor surgical procedures, that you explain what you're doing. And if the family's there, explaining that. It's also important, as was in this case, to say, I don't see any evidence of a tendon, or nerve injury. And the other one is, wounds always heal with scars, but I'm going to try to make yours as small as possible. So that conversation, and if you do that routinely, it makes the patient feel better, and it just alerts people, that you're doing everything you can to make that better. So, all right. Now, a little bit about Marcaine and xylocaine. They're relatively equivalent. The 0.25% of the Marcaine is equivalent to about 1% of the xylocaine. The onset of action, say that lidocaine may be just a little bit faster, but not really significant. What's important is the Marcaine may decrease the need for post-procedure analgesia compared with xylocaine. And it has a longer acting life. Now, this next one is a great, I'm not going to go through this, but it's a great thing to have on hand in terms of looking at the difference between lidocaine with epi, and Marcaine with epinephrine in terms of the formulations and the durations of action and the types of doses. So well worth having that information at your fingertips. Some more local anesthesia tricks. If you have some anesthetic that you can keep in your coat pocket, keep it warmed a little bit. It's less painful than when injected. And so if your ear, oh, it's weird. Sorry. Nobody ever calls me until I'm up front doing something. Anyway, so consider carrying a bottle in your pocket if your ER will allow you to do that. And some alkalized lidocaine is less painful when injected. pH is raised from about 6.6 to 7.7. A lot less burning, easier on the patient. Sometimes you may have to get the pharmacy to label it so that you have the right kind of anesthetic there. Using the smallest gauge needle possible, 27 or even a 30. You may have to have special order to do that. It reduces the amount of pain, and inject it slowly. I don't know. I've had the experience where I've not injected it slowly, and what happens, the needle just pops right off, and then you have to redo that. So larger syringes don't have as much pressure, but they don't work as well. You want to use small needles. Also, when you're injecting, avoid multiple needle sticks. Pull back and redirect rather than repuncturing the skin. So getting the needle into the wound itself and moving it around. Again, injecting through the open wound, not through the intact skin, is very useful. Okay, and what about nerve blocks of the face? You know, if you're really good at this, you know, a great thing to block the area so that you know, the anesthesia lasts a lot longer. Just important to know how to do that. And if you don't do it very often, you need to find somebody who does, or you know, get some additional training to do that. And also, it's important to make sure to know the anatomy on the face in terms of where the facial nerve is and the parotid duct, so that we don't cause additional injuries. Okay, some more things about facial lacerations. We've all heard it, don't shave the eyebrows off because they may not grow back. I've never seen a case where that's occurred, but I'm not going to take the chance. If you have lid lacerations that transect the margins, then you have to align the two sections. That needs to be perfect. So, you know, if you're messing with the eyelids, you may want to get, you know, a specialist to come in and take care of those kind of lacerations. Same thing with through and through lip lacerations. You need closure of the front, back, and the middle of that lip laceration, and get good approximation so that it heals well. Also, through the vermilion border, you need perfect alignment. And the only way to do that is to make sure you can see the area. So you might have to have, you know, the magnifying glasses to get close in there to see if you align it up good. If you do that, then there's minimal scarring. And, you know, these are the kind of things that if you're at all uncomfortable about, you know, get the physician over to take a look at it and get get a consult to see whether someone else ought to be doing that. Okay, what about foreign bodies? Well, we talked about that case a minute ago. It's important that we do know that organic foreign bodies may cause infections. In the case we just talked about, you know why the fungus was there is something for a further discussion, but getting all the organic foreign body out of a wound is extremely important, and so that's going to take some time to irrigate and to visualize and do all the things that we have to do. But the other side of that is you also don't want to irrigate so much that you damage the tissue. So that's the sort of the dichotomy there. So you have to make sure that you legitimately look and find any organic material and get it out of there. And what about glass? You know, any type of glass except the very, very small slivers, you know, may show up on X-ray. And so it's not a bad idea to get a film just to see if there's any glass or other types of foreign bodies there. And I've told patients this, you know, if they've had a bad wound that had a lot of glass in it, we got as much out as we can. You know, if some glass remains in there, you know, the body's really good about this. It will push those little particles of glass out over time. Especially in tight places, fingers, you know, if there's small glass fragments, we need to take the time to try to get those out of there. And as I mentioned earlier, it's wise not to tell patients that we got all the foreign bodies out of there because, you know, sometimes it's impossible to do that. In fact, how do we know? Many of the times that we've sewn up lacerations after cleaning out foreign bodies, there may have been foreign bodies in there, you know, but it either absorbed or it came out somehow. So, okay. So when a foreign body is suspected in a wound and imaging is attempted, it's important to use the right study. Now, obviously, it's real easy to get an X-ray, but sometimes, you know, getting an ultrasound may be worthwhile too. Ultrasound may miss some organic foreign bodies, but sometimes it's better than a plain film. Especially, you know, if visualizing a toothpick in the sole of the foot or some kinds of foreign body that if a nail went through a shoe and there may be something that's opaque enough to see. And what about puncture wounds? You know, most of the information on puncture wounds, you know, is anecdotal. There's not a lot of literature about, you know, what to do. But we do know that we need to find and remove any foreign bodies, even if we have to consider coring, you know, the puncture wound under anesthesia to see if there's a foreign body in there, especially if it's gone through something, a shoe or something else that may push foreign body in that area. Early infections of foot puncture wounds are usually staph. Sometimes the infections take a while to occur, sometimes even a matter of weeks, and actually can end up being Pseudomonas. The real question is, what do you do with puncture wounds, especially in the sole of the foot, in terms of antibiotics? It's really not the standard of care, to use prophylactic quinolones with foot puncture wounds. Okay, other type of wound repair tips. It's really important to debride devitalized tissue. You have to be very careful when you do that with the face. You don't want to cause more damage. Also, in the areas of lacerations where there's fat or dead space, you need to try to debride that best we can. Otherwise, it leaves room for little hematomas to form. An optimal scar requires minimal tension. So when you're doing a laceration, tension is not our friend. The more tension there is, the more damage that can occur, and it can leave more of a scar than we would like. And so it's important to take the time, maybe even do multi-layer repair of lacerations. It's important to know that even absorbable sutures are considered foreign bodies, so we need to decrease the amount of those that we have. Monofilament absorbable sutures are associated with less bacteria in wound management than multifilament. Okay, now here's a good picture of a laceration on a finger. Sutures with tiny loops can be very difficult to remove without ripping them out. We've all seen that. I think there ought to be a rule is whoever puts in the sutures ought to take them out, but that never happens. But I'm sure you've seen lacerations that, you have to get a magnifying glass and then a double magnifying glass to be able to get down there, and then you still have to clear out the crust to get down to the very small ones. So sometimes we use a little bit of a scalpel to get in there and get those lacerations taken out without ripping and damaging the tissue. So as in that picture there, the sutures that are too tight, can cause what we call railroad tracks, marks when removed, and may be there for some time and are not very, they don't look very good, and a lot of people do not like those. Some of the kinds of sutures that we do, subcuticular sutures using non-absorbable material can be a great way of closing straight line lacerations with minimal wound tension. Just pull it through there. I actually like this. Then you just tie the knots at both ends, and then you reinforce it with tape. So for linear lacerations, this is very useful. Simple and locking running sutures. It's not considered lazy if you just want to use some running sutures. It's how I learned, to sew up lacerations. The cosmetic effect of these is really good, and since each loop of the suture requires its own personal knot, now don't need that with this. So, and if a wound becomes infected with this kind of a running suture, you can actually cut out part of the suture, but the other rest of the suture line remains intact if you're trying to open up the area because of an infection. Mattress sutures, we've all done those. Helps close the deeper tissues through the skin, three different areas there that we've done. Pre-tibial flap lacerations. Boy, these are really hard. We've seen them. You see them a lot in the elderly. Very difficult to repair. And I don't know if you ever tried to do that, but a lot of times if you try to repair these, by sewing them up, it becomes a vicious circle because the more that you try to pull the skin together, the more it rips. So most of these are best served, with steri strips or some type of tape to try to bring the skin edges together. Corner stitches, yeah. So it's really easy to look at that corner and say, boy, if I just put a suture right through there and pull it together, it's going to bring this laceration together. You have to be careful and not do that. Not put a single suture through the tip of the V. It just puts too much tension on the wound. In X-shaped wounds, the corner stitch can also be used, as it's shown here. Staples. Another thing that I'm so happy to see over the years that we've used more of. I used to pull call at an emergency room in South Phoenix, Phoenix Memorial Hospital. If any of you are from Phoenix, used to be called the Knife and Gun Club emergency room because people would just drive by and throw people on the front. And I'd get calls at 2 in the morning and say, Randy, can you come over, help us out a little bit? And I knew that means that they had 6 or 7 people who were in there that needed to have, their scalp stapled. So you'd go in there for 4 or 5 hours, just staple away. Great stuff. They're great for the scalp. Can also be used on the trunk and extremities. And just a great thing to have, and it's something that can be done quickly. And it's really important when you do that we get the wounds, approximated together and of equal heights. And stapling produces less infections than the traditional sutures. Here's something else that is extremely useful: the use of tissue glue. This again helps in the amount of time in taking care of lacerations. I had a PA friend of mine call me one day when I was in the ER and said his son had fallen in the garage and got a little laceration, and he says, well, I'll just sew this guy up. So he cleared off the kitchen table and put his kit up on there and got out his suture kit and got a syringe out and went over, and he couldn't do it. And I just couldn't sew up his own kid. So he calls me and says, could you come over and sew it up? So at the door, I grabbed a little bit of glue, went over, in the space of 5 or 10 minutes, glued this laceration, and so to this day, this kid who's now like 22, I'm his hero now because I took care of that. He sent me a little note that said, thanks for fixing my head. And so anyway, I digress. Shouldn't use these things in high tension areas or those that stay moist because they may not work as well. Also shouldn't do this when there's a higher risk of poor healing. Great cosmetic results with these. Wound rechecks with lacerations that are glued are usually not required. It's important to know to not put any antibiotic ointment or petroleum over it because it may dissolve the glue. All right. Prophylactic wound antibiotics. A lot of controversy about, whether we ought to be using antibiotics. Little data to support its use, but perhaps we ought to consider using antibiotics in, animal bites that we suture, obviously heavy contaminated wounds, open fractures, especially tuft fractures, to help avoid osteomyelitis, through and through mouth lacerations just because of the high increase of infections there, hand and foot lacerations, and certainly those in the immunocompromised. Oh, interestingly, that story I told you about the guy that fell off the roof, he also was on prednisone, like 40 milligrams a day, and so you sort of putting some things together about why he might have been a little immunocompromised and end up with a fungal infection. Okay, follow-up of sutured wounds. The incidence of wound infections through the emergency department is very low, about 5%. The infection rates vary by location, the lowest on the scalp and face, obviously the highest on extremities. Studies show that patients obviously are not good judges of whether their wounds are infected. In fact, any kind of redness on there will make them think it's infected. So it's good to talk to the patient, maybe explain to them, here are the things I want you to look for. Routine wound checks, again, in 2 or 3 days is a good idea. It's a good patient care. It's also good to make sure that the patient knows that you care about what's going on. Also ask the patients, what, in terms of wound care, is to remove the crust over the lacerations, maybe get some cotton-tipped applicators, get a little peroxide, and have them learn how to do some daily wound changes and how to remove those crusts. That's going to be very helpful. Okay. Here's some suture removal guidelines just for you to have. Basically, what I tell people is that the further away you get from the face, the longer it's going to take, for the wound to heal and the time to take the sutures out. So this is a good guide for that. Lastly, tetanus. It's about 50 cases a year of tetanus in this country. Most of them are either in the elderly or in those who were previously unimmunized. So patients who have clean wounds, who've had their last booster, greater than 5 years require a TD or a tetanus toxoid. Patients with clean wounds who've had a tetanus booster less than 5 years don't require any kind of vaccination. If they've not had at least 3 doses of tetanus vaccine as a primary course, then they should receive tetanus immune globulin and the TD or the tetanus toxoid. And there's a lot of information out there, and that sort of tends to change every year in terms of when to give the tetanus and when not to. Obviously, patients with grossly contaminated wounds, if their tetanus booster was greater than 5 years, they may require the tetanus immune globulin and the TD or the tetanus toxoid. The Tdap is now advised for everyone over age 19 at the time of a tetanus booster, just because the incidence of pertussis is going up, and a very important thing to do. If you haven't had that, you may want to consider that. All right, so we've spent the last little while just talking about tricks of the trade for, for soft tissue and wound lacerations. And I think we'll move on. I think, Dr. Henry, you're up next. Thank you very much.